joint. So next I am going for, I think, am I audible to everyone? Hello?
Sir, yes, sir. You
Sir,
are audible.
we can
You are
hear
audible.
you, sir. Yes, sir.
Yeah. So I briefly first present my presentation in a few slides, then we will go for the interactive session. Okay. Right. So what is CTEV? So the definition itself is a rotatory subluxation of TCM joint, tallow, calcaneo, navicular joint complex, where talus is in a plantar flexion and subtalar complexion medial rotation and elevation. So the foot is having so many deformities inside, not like a single deformity like a varus or a valgus. That's why it is called club foot. Club means a mixture of more than 2 or 3. That's why it is a club foot. So the origin of the talipus is derived from the ankle and foot. Talus means ankle, pes means foot. Equinovarus is also having other meanings. Equino means like a horse, varus means turned inward. I think till this point we are very clear. So the exact joints which were involved are tallo-calcaneal joint, navicular joint. Talus, under the talus is the calcaneus, in front of the talus is the navicular. So this is the main joint. Talus, calcaneus, and 3 tarsal bones involves main deformity prime factors of osseous elements. So the bony elements which are main causatives for this club foot are talus, calcaneus, navicular. These 3 tarsals which are forming themselves as a joints, talocalcaneal joint, talonavicular joint, and subtalar joint. So etiology, coming to the etiology, idiopathic and secondary. So congenital comes under idiopathic variant only. The reasons for this deformity are when the baby is in the uterus during the gestational period, if oligohydramnios is there as a one of the entity, and if there is a big size baby, the uterus is small to accommodate such a baby, the body parts will adjust in a different positions, not in a comfortable position. At the same time, raised intrauterine pressure forces and ischemia of calf muscles and genetic. These are all comes under idiopathic CTEV. Secondary CTEV is associated with primarily somewhere else there is a deformity causing factors like spina bifida, where the spinal elements which will come to the foot are involved. Then the presentation will be in a club foot like manner, but the causative is not at the foot, mainly at the somewhere else. That's why it is called secondary. Poliomyelitis, myelodysplasia, arthrogryposis, multiplex congenita, and Friedreich's ataxia. So many other causes are there, secondary CTEV. So mainly in a congenital CTEV, either idiopathic or a secondary CTEV. In idiopathic, the reasons are raised intrauterine pressure, ischemia of the muscle, and genetical. In secondary, other than the local foot and ankle, there will be elsewhere other causative reasons are there. So these are in presentations regarding the different deformities of the foot. Not only for the CTEV, this is for overall idea I am presenting here the deformities. One is that equinus. It is a plantar flexed position with midfoot concave and heel is upward and forefoot is touching the ground. In normal foot, there will be, if you see the planus one, the forefoot, midfoot, hindfoot touch the ground, and at the midfoot level, there will be small medial plantar arch. But deviation from this normal foot anatomical position, these are the other deformities. One is equinus. Second one is the calcaneus foot, means the calcaneus is touching the ground and the forefoot and midfoot are not touching the ground and they are making some angulation to the ground in an upward direction. Varus, if you see the varus, the outward bending of the lateral aspect of the foot is varus, the reverse is valgus, and cavus. In the cavus, you should not confuse cavus with equinus. In a cavus, there is a midfoot deformity only. Hindfoot and forefoot both are touching the ground. Whereas in equinus, only forefoot will touch, midfoot and hindfoot both are off the ground. Another one is palanus and splay. So now the components of the deformity, 4 components. Cavus. So now coming for this cavus deformity. This deformity will be there. Exaggerated medial longitudinal arch at the midfoot. So this deformity one. Adduction. So adduction deformity where it is occurring, forefoot in adduction at tarso-metatarsal junction. So in a foot there are 5 metatarsals and tarsals. So metatarsal bases will form the tarso-metatarsal joints. So at that junction, forefoot will be in a adduction. Varus, third component is the varus. Hindfoot rotated inward. Hindfoot rotated inward. So that is varus. And equinus, foot fixed in a plantar flexion at the ankle joint. So if we are coming for this combination of these 4 deformities, there will be a mnemonic everyone knows. Cave, C-A-V-E, cave. For the cave is a mnemonic, C for cavus, A for adduction, V for varus, E for equinus. This is very important to remember which deformity at which part of the foot and ankle, because when you are correcting, if you don't know where the deformity is existing, it is very difficult to address that point to bring it back to normal position while correcting. So these are the deformities. Till now, okay? Hello? Hello?
Yes,
Hello?
sir.
Till now, okay. Right. Next, radiographic evaluations. So the radiography is very difficult to get in a children, newborns, because the interpretation of the proper X-rays is difficult because baby will not allow to take the proper X-rays, number one. And number two, bones are also may not be formed for everyone. So the radiographic evaluation is one of the criteria for assessing the deformity grade. So mainly there are some certain angles we will take into consideration. In the anteroposterior and lateral views, we will calculate talocalcaneal angle. So usually it will be 35 in a lateral view and 25 to 35 in a AP view. But it will be reduced in a club foot. Along with that, we will check for the calcaneo, cuboid and first metatarsal angle also. So now come to the treatment part. So in a treatment part, there are three types of treatments available. One is that non-operative, second one is the operative, and in a operative methods, sometimes we will combine with certain part of non-operative. At the end, we will go for a operative little bit intervention. So non-operative manipulation alone, manipulation of the deformity by mother, day one we will advise. The deformity will be corrected from forefoot. The forefoot is in a adduction deformity. Midfoot is in a cavus deformity. Heel will be in a varus deformity and whole foot will be in a equinus deformity. So we are correcting the deformity by addressing opposite movement to the existing deformities. So when there is a adduction of the forefoot, we will advise abduction. When there is a varus, we will advise for a valgus stress, valgus movement. And when there is an equinus, along with this combination of this forefoot abduction and valgus heel positioning with the dorsiflexion of the forefoot will neutralize the deformities of the foot and ankle. So manipulation and POP application is by kites and Ponseti method. So initially the kites method was used and Ponseti modified that. In a kites method, the concept was the forefoot deformity is the main deformity to address or to correct the whole CTE. But in a Ponseti method, not only forefoot adduction deformity, there is a bony element of talus and navicular bones are taken as a fulcrum. So they, along with forefoot adduction, dorsiflexion and aversion and abduction, these three components are the very essentially addressed, which were neglected except forefoot deformity in kites. So this is 6 times a day by mother whenever she is feeding the baby. This manipulation is advised, and serial plaster casting is advised to prevent the deformity to reappear. So once the deformity is with mother's manipulation, if it is corrected, okay. If it is not corrected, we will do Aboni POP casting in a position of flexion at the knee joint and deformity corrected position in the ankle and foot. Why flexion at the knee? It is to relax the gastrocnemius muscle. When the gastrocnemius muscle is relaxed, the correction will be easy at the forefoot. In an extension, the gastrosoleus component will be very tight and it will prevent some deformity correction tough. So the cast is applied in a knee flexion and foot in a neutral position. So in a first attempt only, we will not get always the corrected position. It will be gradually improved. So like that, when we will stop this plaster, Once we will get corrected forefoot adduction deformity into abduction, not into neutral. Our aim is to get the foot in a abduction of 70 degrees nearly. And the heel varus means which is inward heel. It should get a neutral heel. So if you observe the CTEV foot, it looks like a bean shaped where there is a medial concave and outer border, lateral convex border, and medial border is tight. There will be increased creases. This how the clinical picture of the club foot looks like. But after correcting, the medial concave border should become like a normal plantar arched normal foot, and lateral convex border of the foot also should become a straight one. And cavus deformity and equinus deformity should be corrected and it should be in a neutral position. So that's why if you are clinically able to get normal looking foot, then the plaster cast will be removed, and to prevent further deformity, we will give a CTEV shoes. So how this CTEV shoes looks like? So the CTEV shoe is having straight inner border, outer heel raise, lateral heel raise. This is very important. This will prevent further deformity. So after that, Dennis Brown splint. This splint is also having immobilization bar in between 2 feet. Because when baby is taking sleep, they will do flexion and kicking of the straightening of the legs, which will causes further deformity to recur. So these are the two methods, splints which are used. One is CTEV shoe, another is Dennis Brown splint. Dennis Brown splint can be applied till the baby start walking, or sometimes to 1 year, up to 1 year also. So operative methods are two procedures. One is soft tissue procedure. Second one is the bony procedures. Less than 3 years, the posteromedial soft tissue structures release. The posteromedial structures, flexor hallucis longus, flexor hallucis brevis, tibialis posterior, these are the structures usually in a contracted position. So these will be released. After 3 years, there will be some sort of skeletal maturity, and with the soft tissue procedures, if the deformity is not getting corrected, we will do a bony procedures like a Evans operation, wedge tarsectomy. About 12 years, which are rigid and which are not corrected by other methods, we are going for a triple orthodesis by what the three joints I told you, fusing that three intertarsal joints and making the foot more stable. And more of, many times after doing serial plasters, we will do tendoachilles lengthening jetplasty to prevent, to release the tight tendoachilles to correct the deformity. Usually we do, when we do serial casting, we will do the tendoachilles lengthening as a procedure of the last cast. Just the tendoachilles tenotomy and casting will be combined. And this will be kept for a fortnight or a 10 days because the tenotomy wound will heal by that time. So this tendoachilles lengthening again done by 2-3 methods are there. One is needle, by using a percutaneous needle, release the tight tendoachilles will be made holes, and with the force of minimal dorsiflexion, the deformity will be corrected. Needle tenotomy. Or by surgical method by percutaneous tenotomy of the tendoachilles. So these are the steps we have to remember in the treatment part. In brief, this is regarding the CTEV. I would like to just combine everything what I told in these 5 slides. So exactly the CTEV is the deformity at the ankle and foot, at subtalar joint and ankle joint. So the main tarsals involved are talus, calcaneal and navicular. Along with that, rotation and inversion of the foot. The etiology is idiopathic and secondary. Idiopathic because of the uterine hypo. There are different thoughts. These 3 thoughts. One is ischemia of calf muscles, raised intrauterine pressure forces, and genetical is the idiopathic cause. And secondary causes are elsewhere, somewhere primary will be there. Deformities are 4 deformities: cavus, adduction, varus, and equinus. Cavus at the midfoot, adduction at the forefoot, varus at the hindfoot. So this is the very important. Adduction at the forefoot, even though there, but we, for our convenience, cavus came first at the midfoot, cavus at the midfoot, equinus at the ankle joint. So these are the 4 deformities where they are occurring the point of the deformity in the foot and ankle. The point of deformity also we should know. Very important. Cavus at the midfoot, adduction at the forefoot, varus at the hindfoot, equinus at the ankle. And radiographic evaluation by tibiotalar angles, which are reduced, or there will be parallelism of the tibiocalcaneal, sorry, talocalcaneal angles, talocalcaneal AP and lateral views. These are the AP view angle. This is the lateral view angle. And treatment by non-operative, Ponseti method and mother's manipulation alone. Operative methods by posteromedial soft tissue release, tendoachilles percutaneous lengthening, and bony procedures. So complications of non-operative treatment and operative treatment. Sometimes over-enthusiastic treatment will also causes exaggerated other positions. So rocker bottom foot or a vertical talus. So the talus is overstretched, then it rocker bottom foot will happen. Bean shape, this is the exactly opposite to the CTEV. Fractures, pressure source, failure of correction, recurrence or deformities. So these are all complications for non-operative treatment. In a non-operative treatment, there is a always chance of, there is in a club foot, medial concave border, lateral convex border. So baby start walking on a lateral border because medial border is off the ground, heel is off the ground. So whole weight will be taken on the lateral border. And this talus bone also is in a prominent way because talus is in a subluxated position in a CTE. So there will be pressure source over the lateral aspect of the foot when you are not addressed at early. So thank you. Now we can go for a discussion. If anybody want to ask this some questions regarding that, I am interested to answer. Am I audible?
Sir, yes, sir.
Okay, okay.
If anybody has any questions, please ask them or you can type them in the chat box.
I would like to go for DDH then.
Hello.
Hello.
Good evening, Akshatrama. This is Dr. Radha from Guntur.
Radha, madam. Okay.
I'm your classmate, MBBS classmate.
Oh,
Radha.
Radha Madhi. Okay. Nice,
How are
nice.
you?
Fine, fine. Yeah.
It was my daughter who was, I think, going on asking you and troubling you. There was starting the session and all that.
Oh, okay.
She's my daughter.
Very
Very
nice.
nice presentation, Akshatrama. I was also listening to that the moment she said this.
Yeah,
Who
actually,
was presenting?
yeah, for undergraduates, I want to tell them in a very simplified way to remember and everything.
Yeah, it was very easy way, and probably they can remember it. Actually, they don't have to again read it. I think they can just go through your slides and write the answer. It was a nice presentation.
Thank you. I'm surprised to uh, have a talk with you now.
I'm happy.
Yeah, I'm also
Actually,
feeling.
I have one doubt about CTV, Ashutramaya. Is it diagnosed antenatally?
Yes, it is diagnosed.
Achha, so in the antenatal scans, we can ask that. I mean, if we have any doubt, or is it possible, like suppose one sibling has it and the subsequent sibling also may have it? Is it possible like that?
Yeah, it is possible. How? Because the foot positioning might be very difficult to get in an ultrasound. But we can say it is a outer convex border, medial concave border. All these things clinically manifest once baby is out, but inside the in a TIFA scan, what you are asking, compared with DDH or a spina bifida, this is very difficult because radiologically also X-ray calcaneo talocalcaneal angles, we are having a consideration for the deformity to assess and clinical assessment. But with radiographic, there is no such a absolute guidelines to intraiterainly to judge.
Only like once. So it is only once the baby is delivered and then we see CTV, we have to diagnose.
Is it not? You can put some more information regarding this because, uh, as per my knowledge, it is not that much easy to identify clubfoot in antenatal scans.
So probably once the baby
What do
is
you?
delivered and once baby is delivered, I think we can look at the food and then only we can diagnose it. It's not possible to say that beforehand we can diagnose it.
Yeah, because to accommodate body inside the uterus, whatever the position looks like abnormal, we cannot come for conclusion because after delivery, they may back or because of elastic nature of the body parts, they will present as a normal.
Okay. So thank you, Achutrama. Thank you so much. I think if you have other people to interact and other delegates, if they have doubt, I think you can go ahead. It was nice talking to you. Thank you, Achutrama. Thank you so much.
Thank you, Radha Madhav.
Sir, Ravi sir wanted to say something, sir. He raised his hand.
Yeah, please, definitely.
He's not in the meeting, sir. I think he has a network issue.
Please, Ravi sir. Chat box.
Sir, will you begin the next session, sir?
Yeah.
Yes, sir.
You have to stop sharing, sir. You have to first stop sharing.
Yeah.
Close this PPT, sir. Open the next PPT. Open the next PPT and the same, sir. Share and select the only PPT window, not the screen windows. Yes, sir. It's visible, sir. Click on the slide mode, sir. Slide mode. Yes, perfect, sir.
So again, briefly, I would like to tell about DDH. Previously, it called as a CDH, congenital dysplasia of hip, but now it is termed as a developmental dysplasia of hip. So we are briefly going through very same method like introduction, etiology, clinical features, investigations, and treatment. So then developmental dysplasia is basically the hip joint itself and the surrounding structures of the hip joint are the main causative for this. One is the acetabulum, other one is femoral head. Around them is the capsule or a labrum and some muscle structures which are lying anteriorly and posteriorly. Anteriorly, the iliopsoas muscle. So these are the structures which will give some sort of deformity at the hip, which can be diagnosed very easily by some clinical maneuvers after birth. And before that also, the position of the femoral head relatively in position with the acetabulum. So here, the spectrum of disorder consisting abnormal development of hip, which is resulting into either dysplasia, subluxation, possible dislocation or definitive dislocation, secondary to the capsular laxity and mechanical stability. This can occur as spontaneous dislocation of the hip before birth, means in the uterus, or during the process of delivery, or shortly after the birth. It is uncommon in India, but we are seeing these cases also. So etiology, the hormone-induced joint laxity, mainly estrogenic, malposition in the uterine cavity breech malposition, and a hereditary predisposition of joint laxity where collagen involved, collagen metabolism involved, connective tissue disorders. But some of the clinical findings, it commonly firstborn babies, female are more affected than male. There will be skin fold asymmetry and limited range of movements at the hip, especially abduction, and unequal femoral length. So the first two cannot be explained easily, but the other things are clinical features which can be explained very easily. So skin fold asymmetry, because of the abnormal arrangement of the structures around the hip, there will be more creases. Because migration of femoral head from normal position to upward, there will be shortening of the femur length. And then because of the femoral head is not inside the acetabulum, that means it is not in a containment. there will be limitation of the abduction moment. So these two tests clinically commonly asked. One is Barlow's and another one is Ortolani's test. In a Barlow's test is a provocative test. Ortolani's test is the test or a maneuver to reduce. Means in a definitive dislocation is there, Ortolani's test will become positive. But Barlow's test will give you only information regarding dislocatable, not confirmative. It is a provocative test. In an unstable heap, by doing maneuver, we are testing to dislocate the heap. The maneuver consists flexion, adduction, combined with posterior push. If we see here in the picture, the thumb is placed along the middle aspect. This is the acetabulum and this is the femoral head. In a supine position, we hold both knees and gently adduct one hip, adduct, and push posteriorly, the downward direction. Adduct and posteriorly. We'll feel the femoral head make small jump or click sound out of the acetabulum. This is called Barlow's sign. When pressure is released, the head is felt to slip back into the place. This is Barlow's test. Whereas coming to the Ortolani's test, this is the maneuver to reduce dislocated hip. Here the movements what we do, flexion, abduction and anterior thrust. It can be again palpable clunk. Here the exam we hold the infant knees both and we will stabilize the pelvis or a trochanter femur by fingers. Our ring finger and little finger will support the trochanter and thumb will be along the medial aspect. So we do opposite movement. We will do abduct while lifting up the greater trochanter with two fingers. Here is the fingers and we will abduct. The test is positive, the dislocated femoral head will fall back into the acetabulum. So we are reducing here. Here, if you see, here it is in a reduced position. So we are reducing. It is a maneuver to reduce. So we should not get confused with Barlow's and Ortolani's. The investigations, coming to the investigations, very, very important. Ultrasound scan, plain radiograph, CT and MRI. In ultrasound scan, we will get joint outline. There are a typical angles formed by the acetabulum and femoral head. We will measure plain radiograph of both hips to compare with the normal with abnormal, CT scan and MRI. So here in a plain X-ray, there are two lines we will take as a reference lines. One horizontal line which goes through the triradiate cartilage. This is the triradiate cartilage. The line connecting the triradiate cartilage. This is the triradiate cartilage. Ilium, ischium, pubis. These three are three innominate bones where this triradiate cartilage joins these three bones. these three bones will form the hemipelvis. So this point is called triradiate cartilage. So here also triradiate cartilage. So if we put 2 points here and we extend the line parallelly, longer line, that is one line. Second line is the acetabulum superior border and outer line, outer border. So if this is the acetabulum, this is the superior border. From the superior border, we will give a one line, vertical line on both sides. So these two lines will make right angles to each other. Now we will come to divide four sectors: upper medial, upper lateral, lower medial, lower lateral. So ideally femoral head will lie inferomedial part. But in a dislocated hip, the femoral head will not present in its normal position. That is one. Another one is the Shenton's line. Shenton line is a femoral neck medial border, femoral head medial border, and obturator foramina superior border, or superior pubic rami inferior margin. This will make a continuous line. This is Shenton's line. But in a dislocated hip, the Shenton line will be in a broken position. So these are the two. One is the femoral head position with the two lines formed, two lines drawn. One is vertical and another one is horizontal. Vertical line is called Perkin line, which is drawn along the outer border of the superior acetabular margin. One perpendicular line. Horizontal line is through the triradiate cartilage. This horizontal line is called Hilgeniner line and vertical line is called Perkins line. So femoral head and neck usually lies in the inferior and medial quadrant. But here it is going abnormal in position. And another indirect evidence is that Shenton's line break. Another one is CT scan and another one is MRI scan. In MRI scan, we will get additional features of labral defect or a contracture of iliopsoas muscle or a joint capsule fibrosis or a break in the joint capsule or obstructing structures inside the acetabulum. Why femoral head is not in a normal position or a shallow acetabulum. All these things we will get in a bony information from CT and soft tissue information from MRI. So now coming for the guidelines for treatment of DDH. Pavlik harness for 6 weeks. So Pavlik harness is a splint where you can see the reduction forces are applied indirectly through the harness to reduce the hip and to avoid the movements where the joint is in a reduced position, in a reducible, in a dislocatable position. Because when baby starts giving movements at the knees, ankles, hips, there is a high chances of, even though you reduce, for getting dislocated into repeatedly. So that opposite movement we will apply through the Pavlik harness to reduced position to maintain. So there are flexion straps and abduction straps here. These are the two straps very important. So we cannot get control by applying from here waist. That's why we are going above chest and shoulder also straps. So these are the acting like a additional supports to prevent the movement at the hip joint where dislocation repeatedly happens. After that, first 6 months Pavlik harness, 6 to 18 months closed reduction and hip spica application for 3 months. Hip spica is more stable and more rigid, and there is no chance of redislocation again. After 1.5 years, we are going for a bony procedures where either femoral or a acetabular components can be addressed. So in a shallow acetabulum, we will go for a shelf osteotomy. We will create acetabulum by doing the osteotomy of the pelvic bones. If the acetabulum is okay and femoral head is not contained well, we will do femoral shaft osteotomy, rotational or a varus osteotomy to put the femoral head inside. From 2 years to 6 years, open reduction only advised because it is very difficult to reduce by closed methods after 1.5 years. Primary open reduction, femoral shortening with or without Salter's osteotomy. So the components bony procedures are, if acetabulum is shallow, you have to create a acetabulum by doing the ilium osteotomy. And we will fix the ilium with the pins. And we will create the acetabular surfaces to cover the femoral head. If there is no issue with the acetabulum, then we will go for the outward pushing forces which were happening at the femur. We will do derotational and femoral shortening osteotomies to contain the femoral head inside the acetabulum, and we will apply plaster cast to prevent the dislocation happen after surgery also. After surgery also we have to apply hip spica cast. It is also called a frog leg cast or a bachelor's cast. Here you can see both the hips are well casted and kept in a abduction, because the maneuver adduction is whenever there is a movement of flexion, adduction and internal rotation at the hip is going to, femoral head is going to dislocated. There will be a mnemonic again, F fair, F for flexion, A for adduction, IR for internal rotation. So we will do opposite. We will do, if it is in a flexion, we will do in a abduction and external rotation, or if it not in, even though in a flexion it is getting reduced, getting dislocated, we will do in extension of the knee joint. Whenever there is a flexion at the knee, there is a always little flexion at the hip. With that little flexion, if the hip joint is not reduced, we can give the POP cast in a flexion. But with that little flexion at the hip, when you are doing flexion at the knee, if the hip is getting dislocated, we won't take chance, we will do in a extension position. And another splint is that Van Rosen splint. So these are the two splints. One is Pavlik harness, another is Van Rosen splint. Another one method is by conventional POP method, by frog leg cast or a Lorange cast. Another one is a bachelor cast. Bachelor cast is applied in a knee extension, whereas frog leg cast is applied in a knee flexion. Bony procedures are osteotomies. One is acetabular osteotomy, another one is femoral osteotomy. They are indicated when there is a failure with the conservative methods, and after 1.5 years, when soft tissue procedures and when non-operative methods having no role. Thank you. You can ask any questions or any
Sir, you can stop the screen share, sir. We can't see you.
Yeah.
If there are any questions, the students can ask them. I think that's a very pretty comprehensive description of CTV and dysplasia hip. Who is the host?
Sir, I am the host, sir. Devika.
Sir is not, sir, please ask sir to start his video.
Sir, yes, sir.
Any questions from anyone? Charan Chandu,
Sir.
any questions? You're a house surgeon, you should be able to at least ask a few questions.
అర్థమైంది సార్ టాపిక్.
సార్ ఐఎమ్ డాక్టర్ ఉదయ్ శంకర్ అండి, గుంటూరు నుంచి నేను ఫిజిషియన్ అండి. గుడ్ ఈవినింగ్ సార్. సార్ మీరు మ్యూట్ అయిపోయారు అక్షతరాయ్ గారు.
సార్ గుడ్ ఈవినింగ్, నమస్తే సార్.
నమస్తే, నేను ఫిజిషియన్ సార్, గుంటూరు నుంచి. థ్యాంక్ యూ టుడేస్ ప్రోగ్రామ్. ఐ థింక్ ఇట్స్ వెరీ కాంప్రహెన్సివ్ డిస్క్రిప్షన్, స్వీట్ అండ్ షార్ట్.
సార్ because orthopedics na sir, if I want to tell for like a MS postgraduate student, it will be they don't like, so
If everything is okay, we can close the session, Dr. Devika.
Okay, sir.
Thank you, Andy. Akshatharav, thank you, sir.
thank you very much sir, thank you for giving me the
Close
opportunity.
the NMO Shanti Mantram,
Yes,
Devika.
sir. Ending the session with the Shanti Mantram. Sarve bhavantu sukhinah, sarve santu niramaya, sarve bhadrani pashyanti, ma kashchid dukha bhagavet. Om Shanti Shanti Shanti. Thank you. Thank you, sir.
Akshatharav garu, namaste.
Namaste sir, thank you.
Sir, thank you, sir. Can I end the session, sir?
Yeah, please, thank you.
Yes, sir.
Thank you very
Thank you
much.
so much, sir. Yes, sir.